Hello, everyone, and welcome to our second module on pulmonary anatomy. Let's start by talking about surfactant, which is a very important substance produced by cells in the lungs in order to improve gas exchange. So when we exhale, we blow air out of our lungs, and the alveoli, which are the gas exchange units of the lungs, will shrink in size. And if they shrink too much, they'll collapse, and we call this atelectasis. And atelectasis is bad for a couple of reasons. First of all, it increases the work of breathing because with each respiratory cycle, if there's atelectasis, we have to reinflate those collapsed alveoli. But second, when the alveoli collapse, we lose surface area for gas exchange, so atelectasis makes gas exchange less efficient. So the idea behind surfactant is that this substance prevents the collapse of alveoli, and we'll talk about how it does this in just a minute. So this has a couple of advantages. First of all, it decreases the work of breathing, so we don't have to reinflate those collapsed alveoli. But then more importantly, by keeping the alveoli open, there's more surface area for gas exchange, so surfactant improves the efficiency of gas exchange. So surfactant is secreted by type 2 pneumocytes. Pneumocytes are the epithelial cells that surround the alveoli in the lungs, and it's the type 2 pneumocytes that produce surfactant. And so what's found in surfactant? Well, it's a mix of lipid substances called lecithins. One of the most important ones is dipalmityl phosphatidylcholine, and that's a mouthful to say, but you want to be familiar with these terms I'm circling here because they may ask you about what are the components of surfactant on your board exam. So to understand why surfactants are so helpful for gas exchange, we have to talk about a concept called surface tension. So you need to understand that the alveoli are lined with a film of liquid. And the liquid-liquid forces, in other words, the forces pulling the molecules of liquid together, shrink the surface area of the alveoli into a sphere. And so we call those liquid-liquid forces where the molecules are pulling each other together, we call that the surface tension. And if there's too much surface tension, instead of forming a nice sphere for gas exchange, like shown here, instead you will get collapse of the alveoli. And as we just discussed, that's bad. The law of Laplace helps us relate surface tension to the likelihood that the alveoli will collapse. So the law of Laplace can be used to determine the collapsing pressure for the alveoli. This is the force tending to collapse the alveoli and cause atelectasis. So a low collapsing pressure is a good thing. It means there's not many forces trying to collapse the alveoli and it's easy for them to remain open. A high collapsing pressure is bad. This means there are lots of forces trying to collapse that alveoli and it's difficult for them to remain open. So two things determine the collapsing pressure. One is the surface tension, which we just talked about. The other is the radius of the alveoli. So when the alveoli have a small radius, this leads to a high collapsing pressure. On the other hand, when there's a large radius, this leads to a lower collapsing pressure. And so all this makes a lot more sense if you look at the equation at the bottom of the slide here, which is the equation for collapsing pressure. It's equal to 2 times the surface tension divided by the radius. So alveoli with a high surface tension and a small radius are the ones that are most prone to collapse. Looking at this another way, if you want to lower the collapsing pressure, an easy way to do that is to reduce the surface tension, and that's what surfactant does, and we're going to talk about that in a second. But it lowers the surface tension, and that way, no matter what the radius is of the alveoli, the collapsing pressure will be lower, and the alveoli will be less likely to collapse. So that's the key point about surfactant. Surfactant reduces the surface tension of the alveoli and it makes them less likely to collapse. So if you look at the bottom of the screen here, if we had very large alveoli, they would have a low collapsing pressure and that would be great. But as you may know, the alveoli are very small. So that creates a situation, according to this equation at the top of the slide here, where we have a high collapsing pressure. But because we add surfactant lowers the collapsing pressure, and so even when we have small alveoli, like we do in our lungs, the collapsing pressure will be low, and that's why surfactant is so important. Beyond keeping the alveoli open, surfactant also increases the lung compliance. It makes the lungs less stiff, more floppy, and this makes it easy for them to expand and contract with each respiratory cycle as they fill with air. So the place in clinical medicine where surfactant is most important has to do with newborn babies. And in order to understand that, let's talk about fetal lung maturity. So when the baby is growing in the womb, the lungs are mature when the baby is able to produce adequate surfactant. That means that the lungs will be able to provide gas exchange after birth. and this usually occurs around 35 weeks of gestational age. So babies that are born at term beyond 35 weeks usually have mature lungs. Babies that are born prematurely, however, may not have enough surfactant, and this can lead to respiratory problems after birth. There is a way we can determine the likelihood that the fetal lungs are mature prior to birth, and that's by taking a sample of amniotic fluid from the mother and measuring the lecithin to sphingomyelin ratio, or the LS ratio. Both substances, lecithin and sphingomyelin, are produced equally by the baby in the amniotic fluid until about 35 weeks. But after 35 weeks, surfactant begins to be produced. And remember, we talked about earlier how surfactant contains lecithins. So this ratio of lecithins to sphingomyelin is going to go up when the baby begins producing surfactant. That's usually around 35 weeks. So we can measure the LS ratio in the amniotic fluid of the mother, and if it's greater than 2, this suggests that the lungs are mature and that the baby is making surfactant with those lecithins in the surfactant. If a baby is born prematurely without enough surfactant present, this will lead to the neonatal respiratory distress syndrome. This is basically a syndrome in newborn babies caused by surfactant deficiency. So what happens when the baby is deficient in surfactant? Well, first of all, there's high surface tension in the alveoli, and this leads to atelectasis. In addition, as we talked about before, surfactant makes the lungs more compliant. So when there's an absence of surfactant, you will have decreased lung compliance and the lungs will be stiff. Because there's poor oxygenation in the absence of surfactant, the baby can have hypoxemia and high PCO2 from poor ventilation. And this can be a major clinical problem because the condition is poorly responsive to O2. The lungs are collapsed because the alveoli are collapsed from high surface tension. And when you have collapsed alveoli, there's no gas exchange occurring in those alveoli, but blood is still flowing past the alveoli. This is called intrapulmonary shunting. Basically, blood is going from the right heart to the left heart without picking up oxygen. And so all of this is very bad for oxygenation, and even when you give the baby more oxygen, it doesn't always improve because of these factors here. And so what I've summarized on this slide are the most important things to know about neonatal RDS for your board exam. They're going to show you a baby who maybe has an X-ray like this shown here. This is ground glass appearance in both lung fields. That's what you can see in RDS. And then they're going to ask you things like, what's happening with the surface tension? Well, it's high. What's happening with lung compliance? It's decreased. What's happening with gas exchange? So you get the idea. So you want to recognize this syndrome and know the fundamental principles that are happening inside the baby's lungs. The major risk factor for neonatal RDS is prematurity. As we've just discussed, the lungs aren't mature until about 35 weeks, so babies born before that are very likely to develop this condition. Another risk factor is maternal diabetes. So mothers who have diabetes when they're pregnant will have elevated levels of blood glucose, and that will go through the placenta and expose the baby to high levels of glucose. This means the baby will make lots of insulin, and it turns out that insulin suppresses surfactant production. So neonatal RDS is more likely in mothers who have diabetes. And then lastly, cesarean delivery increases the risk of neonatal RDS. That's because there's a stress response at delivery when the delivery is vaginal, and this triggers the baby to release cortisol, which is good for surfactant production. So in a cesarean delivery, there's reduced fetal cortisol, and this can lead to a reduction in surfactant production. If a mother goes into labor and we know that the baby is going to be born prematurely, we can administer betamethasone to the mother prior to delivery. Betamethasone is a corticosteroid, and it will stimulate surfactant production in the baby. It increases the amount of that component of surfactant, dipalmityl phosphatidylcholine. And so giving steroids like betamethasone to the mother prior to delivery in preterm deliveries is something that's pretty much standard of care. And then after the baby is born, if the baby has neonatal RDS, we can administer surfactant via an endotracheal tube, and that helps as well. And then beyond this, preterm babies who have RDS often have to be admitted to the NICU. They often need oxygen therapy and sometimes mechanical ventilation for a period of time until the lungs are more mature and able to provide gas exchange. There are a couple of complications of neonatal RDS that you should be aware of. The first one is bronchopulmonary dysplasia. So when oxygen is administered to newborn babies, it can cause free radicals to form, and this can be toxic to the lungs. It inhibits the process of alveolarization, which I talk about in the video on pulmonary embryology. And so after the babies survive neonatal RDS, they can go on to have respiratory problems during infancy because their lungs have bronchopulmonary dysplasia. Many children eventually outgrow this, but children who are born prematurely and have neonatal RDS often have some respiratory problems early in life. Babies with neonatal RDS often can have a patent ductus arteriosus. This is a congenital heart anomaly that I talk about in the cardiology section, but the hypoxia keeps the shunt open so that you have a continuous connection between the pulmonary artery and the aorta, and that's called a patent ductus arteriosus. And then lastly, there's an eye complication of neonatal RDS called retinopathy of prematurity. So the oxygen-free radicals can cause neovascularization of the retina. This means new blood vessels grow in the retina, and this can potentially lead to retinal detachment or blindness. Usually the eye problems are relatively mild and these babies don't end up being blind, but that is a risk that can occur in babies who have RDS treated with oxygen therapy. Okay, so now let's switch gears and move away from surfactant and talk about something totally different, and that is the anatomy of the mediastinum. So the mediastinum is the space in the chest between the lungs, and there are a number of structures found in the mediastinum, and they're going to want you to be able to recognize them on your board exams. So shown on this slide is an axial cross-section CT showing the chest. This black area here is the right lung. This black area here is the left lung. This is the ascending aorta right here, and this is the descending aorta right here. You don't see the aortic arch. That's at a higher level. And here we have the pulmonary artery, which branches right here into vessels that supply the left and right lung with blood. Also shown right here is the superior vena cava. And then you can see these two black holes here. So these are the bronchi. So the trachea has just bifurcated. This is the carina, and we've got the right and left mainstem bronchi shown right here. There are these two black holes. And then not shown well in this image is the esophagus, which usually sits right back here, right near the aorta. And then you can always orient yourself by finding the spine. That's going to be the back. And then the other side here is the front or the anterior, and this is the sternum right here. So the carina, which I mentioned on the last slide, is a term you should be familiar with. It refers to the bifurcation of the trachea. At the carina, the trachea bifurcates and gives rise to the right and left mainstem bronchi. And you can find the carina posterior to the ascending aorta and anteromedial to the descending aorta. To understand what I mean by this, let's look at this CT scan image at the bottom of the slide. So this is the ascending aorta right here, and the carina sits just posterior to that. This is the descending aorta here. The carina is anterior to that and a little bit medial, so we say anteromedial to the descending aorta. And the level where the carina is found, where the trachea bifurcates, is at T4 posteriorly and the sternomanubrial junction anteriorly. So once again, let's look at this image. We've got a spinal process here in the back, and because we're at the level of the carina, where you can see the bifurcation into the right and left mainstem bronchi, then we know this is T4 down here at the bottom. And anteriorly, the level where the carina is found is the sternomanubrial junction. So what do we mean by that? Well, this is a piece of the sternum right here that you can see, this bone here. And then your sternum is made up of three pieces. So the big piece in the middle is the body of the sternum. At top, there's a bone called the manubrium, and then there's the xiphoid process down at the bottom. So this junction here between the body of the sternum and the manubrium, that's the level where you find the carina anteriorly. Let's talk about the anatomic relationship between the trachea and the pulmonary artery. So the pulmonary artery, which is right here, sits right in front of the trachea and the mainstem bronchi. And on the right side, the right main pulmonary artery goes in front of the right mainstem bronchus. So it's anterior to the right mainstem bronchus, which is this structure right here. On the left side, you've got the left mainstem bronchus here, and you can see that the left pulmonary artery goes over the top or superior to that left mainstem bronchus. And so this is just another sort of factoid about the anatomy in the chest that sometimes comes up on the step 1 exam. And the easy mnemonic to remember this is RALS, right anterior, left superior. This describes the relationship between the major branches of the pulmonary artery and the main pulmonary bronchi. You can break down the structures in the mediastinum as fitting into one of three compartments. So if you look at this picture on the slide here, this small compartment here in front of the heart is called the anterior mediastinum. Then you find the heart and the great vessels in the middle mediastinum, and then the posterior mediastinum is where you can find the spinal cord and lots of nerves. And it's important to know what's found in each of the three compartments because a common clinical scenario is a mediastinal mass. And the differential diagnosis for what that mass could be varies by the compartment in which you find the mass, whether it's anterior, middle, or posterior. So anterior mediastinal masses are relatively common, and there's a mnemonic you can use to remember the causes of anterior mediastinal masses, and that's the terrible T's. And so all the bad causes of mediastinal masses begin with a T. So the first T is for thymic masses. So the thymus is found in the anterior mediastinum. I'm circling it right here on this drawing. Half of anterior masses are derived from the thymus. So for example, a thymoma is a common cause of an anterior mediastinal mass. This can occur in association with myasthenia gravis, which is a neurologic disorder that I talk about in the neurology section. The second T is for a teratoma or a germ cell tumor in adults. So germ cell tumors are things like teratomas and seminomas. These often arise in the testicles in males, but they can also sometimes occur outside the gonads. And it turns out that the mediastinum is the most common location for an extragonadal germ cell tumor. The anterior mediastinum is where you find these tumors. The next T is for terrible lymphomas. There are lots of lymph nodes in the anterior mediastinum, and sometimes that leads to development of a lymphoma. And then the last T is for thyroid growth. So the anterior mediastinum is located right near the thyroid gland, and so an enlarged thyroid or ectopic thyroid tissue sometimes presents as a mediastinal mass. Often these masses are connected to the thyroid gland, and that gives you a clue as to what they are. So shown on this slide are the three mediastinal compartments, the structures that you can find in each compartment, and the potential causes of masses in that compartment. And I bolded some things in red, which are the things I usually think of first when I think of this compartment. So for the anterior mediastinum, for example, first thing I think of here is the thymus and the lymph nodes. You can also find mammary arteries here. But many of the masses in the anterior mediastinum relate to the thymus or the lymph nodes. So you can find a lymphoma, for example. You can find thymic neoplasms. Then you can also find thyroid problems and teratomas like we talked about in the last slide. The middle mediastinal compartment is where you find the heart and other vascular structures. So the pericardium is here, the heart, the aorta. You can also find the trachea and the carina here. The main causes of masses here are lymphadenopathy. There are lymph nodes here. So you can see lymphoma here. Sarcoid can cause enlargement of the lymph nodes in the middle mediastinum. You can also find metastatic lung cancer to some of the lymph nodes that are found in this section. And then finally, the posterior mediastinum, I think of the spine and nerves, although you can also find the esophagus. So the masses that occur here are often neurogenic things like schwannomas, neuroblastomas. These derive from the nervous system, and hopefully that makes sense to you because you can find the spine in the posterior mediastinum. Okay, let's talk about the diaphragm. So the diaphragm is a muscle, and it's innervated by nerve roots from C3, C4, and C5 in the spine. These nerve roots give rise to the phrenic nerve, and many people remember this by the mnemonic C3, 4, and 5 keep the diaphragm alive. If the diaphragm is irritated for any reason, this can potentially lead to what's known as referred pain. What this means is that you won't feel the pain, or the patient won't feel the pain at the level of the diaphragm. Instead, they'll feel it in the shoulder because those pain signals are being transmitted through C3, 4, and 5, which also innervates sensory information from the shoulder. So the classic example is gallbladder disease. If the gallbladder irritates the underneath of the diaphragm, that can lead to referred pain. Also, lower lung masses can irritate the diaphragm. And so when these types of problems occur, even though the problems are in the GI tract, in the example of the gallbladder, or in the lungs, in the case of a lung mass, the patient will report pain at the shoulder, and that's because C5 has sensory information to the shoulder, or around the trapezius ridge, because C3 and C4 carry sensory information from the trapezius ridge. And so this is sort of shown in this diagram here, like here's the portion of the shoulder where patients often sense referred pain, also up here in sort of the right side of the neck. In addition to causing referred pain, irritation of the diaphragm can cause dyspnea and also can cause hiccups. One of the reasons people get hiccups is because their diaphragm is irritated and in spasm, and that can lead to hiccups. And then lastly, if you cut one of the nerves going to one side of the diaphragm, you will get elevation of the diaphragm on that side, and then the diaphragm won't function normally, and this can lead to dyspnea. So I've seen this in many patients following open heart surgery. Sometimes those nerves in the chest are damaged, and after surgery, they have chronic dyspnea and elevation of the diaphragm on one side because of nerve damage. You can actually diagnose this by detecting what's known as paradoxical movement. So when the patient inspires, the diaphragm should go down, but one side will move up if there's nerve damage of the nerve supplying that side. You can actually see this on fluoroscopy. It's called a sniff test. patient goes under the fluoroscope, which allows you to visualize the diaphragm, and you ask them to inspire, and then you can see the paradoxical movement on the side with the damaged nerves. The side that moves up is the side that has the nerve damage. There are a number of structures that pass through the diaphragm, so let's talk about that now. First of all, let's look at this picture on the slide here. So first of all, you can see that the diaphragm isn't a flat structure. It's actually curved. In this direction, it's also curved going backwards. And so the openings occur at different levels. Like here's one of the openings here. It's relatively high up. Here's one that's sort of in the middle, and here's an opening down here that's further down. So some structures pass through the diaphragm at a higher or lower spinal level compared to other structures. So that's the first basic point to understand. So let's first talk about the caval opening. This is found at spinal level T8. This is shown right here. It's this higher opening right here in the cartoon. And it's called the caval opening because this is where the inferior vena cava passes through the diaphragm. It's also where the phrenic nerve passes as well. A little bit lower down in the spine, around T10, that's where you find the opening for the esophagus. This is called the esophageal hiatus. It's at spinal level T10, and the esophagus passes through the diaphragm here, and also the vagus nerve, which is cranial nerve 10. And then the lowest opening is the opening for the aorta. That's down here at the bottom. It's at spinal level T12. This is where the aorta passes through the diaphragm, also the thoracic duct and the azygos vein. And a time-honored mnemonic to remember this fact about T12 is T12, it's red, white, and blue. The reason it's red, white, and blue is red is for the aorta, the thoracic duct carries lymph flow, which is white, and the azygos vein carries venous blood, which is blue. Okay, let's talk about the muscles of respiration. And in order to do this, we need to talk about two kinds of respiration. The first kind is so-called quiet respiration. This is the way you breathe when you're resting, like sitting in a chair or sleeping at night. You're not working hard and exercising. You're not trying to maximize the amount of gas exchange. You're just breathing quietly. And so this normal quiet breathing involves only the diaphragm. The diaphragm contracts, and that leads to an inspiration of air, and then exhalation is passive. When the diaphragm relaxes, you just have normal, quiet breathing and airflow leaving the lungs just because the diaphragm's relaxing. No other muscles other than the diaphragm are involved in normal, quiet respiration. When you're breathing during exercise, however, the situation is different. Your body can bring in extra muscles to maximize the amount of air going in and out of the lungs. This can be done during exercise or any form of respiratory distress. So during inspiration, you can use muscles in your neck to maximize the amount of air brought into the lungs. The scalenes shown here in the neck can raise the ribs, and the sternocleidomastoid muscle here can raise the sternum. That's during inspiration. Then during exhalation with exercise or respiratory distress, muscles in the abdomen will be used. So for example, the rectus abdominis muscle can be contracted to push more air out of the lungs. Same thing with the oblique muscles here. You can also use the transverse abdominis and internal intercostal muscles. But the point here is that these abdominal muscles are being pulled in to assist with exhaling more air during exercise or respiratory distress. And clinically, you'll often hear it said that a person in respiratory distress is quote unquote using their accessory muscles to breathe. And what we mean by this is that when you look at a person in severe respiratory distress, you can see the abdominal muscles and the neck muscles contracting, and that's a sign that their respiratory distress is quite severe. And so this term, accessory muscles, you'll hear it used in the clinic and the hospital a lot, basically to describe a person in marked respiratory distress to the point that they have to use all these extra muscles to try and improve their ventilation. And that concludes our second module on pulmonary anatomy.